Good afternoon and welcome. I'm John Iannian, the Director of the Institute for Healthcare Policy and Innovation. It's my pleasure to welcome you to this seminar on oral health policy sponsored by the Institute for Healthcare Policy and Innovation and the School of Dentistry. We're very happy to be hosted here at the School of Dentistry today by Dr. Romesh Nalliah, the moderator of today's program. And just for those of you who may not be familiar with our institute, also known as IHPI, it was founded back in 2011. It was founded in 2011, and it's grown from initially 300 faculty across campus to now about 670 faculty from 15 different schools and colleges at the University of Michigan, as well as our Dearborn and Flint campuses. So all three campuses of the university represented within the institute. And in recent years, we've had an oral health interest group that has been meeting and with faculty from across the university and the institute, thinking about important issues, some of which we're going to hear from our panelists today. So with that, by way of introduction, I also want to welcome those of you joining on Zoom to our hybrid seminar and the room that's nearly full here at the School of Dentistry. We welcome everyone to this hybrid event, and I'll turn it over to Dr. Nalliah to introduce the panel.
Thank you. Thank you everyone for being here. My name is Romesh Nalliah. I'm the Associate Dean for Patient Services, and I'm a member of IHPI. And I want to welcome all the IHPI members who are here and also viewing online. We're really honored to have you. And I must take this moment to do a little plug for the School of Dentistry, okay? So in fall of last year, the School of Dentistry completed a $160 million 4-year renovation. And so it's a beautiful space now, and really want to invite IHPI members to visit or to be patients here. We have every kind of clinic here. We have the student clinic, of course, we have residents delivering care, and we have a private practice where faculty deliver care as well. But reach out to me if you just want to see the premises. I would be so proud to show you, and you can find my information on the IHPI pages. So welcome. We're so excited to have you at the School of Dentistry. It's our honor to partner with IHPI. I just want to tell you a brief little thing about my experience with IHPI, and then I want to turn over to our panelists who are the real stars of today's event. So, I've been involved in studying vulnerable populations for about 16 or 17 years, and I've been at some, really great institutions, but I don't think that my work has been as impactful as when I've been at Michigan, and the reason for that is IHPI. Because IHPI has got me and my work in front of legislators, senators, representatives, the Medicaid office, and various other decision makers in Lansing. And they've sort of reframed my thinking that, I used to think as a researcher, when you publish your paper, that is the work done. But I realized that that's the easiest part. It's the easiest part. The work begins when the paper is published, because now, how is your work going to make change? How are you going to influence policy and guidelines and care delivery? And it's been a privilege to be engaged in that side of the work here with IHPI. So we have 3 terrific panelists, and just to keep the interest, I'm going to introduce them only one at a time. So the first is Dr. Chad Brummett. Chad is no stranger to the School of Dentistry and has actually given faculty development courses here on safe opioid prescribing. So welcome back, Chad. Chad is a professor of anesthesiology at the University of Michigan, where he serves as the Senior Associate Chair for Research. He's co-director of the Opioid Prescribers Engagement Network, Michigan Open, at the University of Michigan, which aims to apply a preventive approach to the opioid crisis through appropriate prescribing, because prescribed opioids are a gateway drug to much heavier medications. And he's done work in emergency medicine, in various surgeries, including dental surgery. So over to you, Dr. Brummett.
Thanks, Romesh. It's a pleasure to be here today. As Romesh said, I'm an anesthesiologist and a pain physician. And in advance, I'd like to give credit to my colleagues, Mike Inglesby, Jennifer Walge, and Mark Bickett, who are co-directors of Open. And then a special shout out to Romesh for being our partner in all of our dentistry related efforts. And then Kao Chua, a pediatrician, who's really driven a lot of incredible work in the last couple of years. And say, we're also very proud to be, Open is very proud to be a signature initiative of IHPI. So I'm going to just do, by way of hands, how many of you have had a wisdom tooth extraction? Okay, less than I would have expected, right? And for those people who had a wisdom tooth extraction, how many of you had opioids as a part of your post-surgical care? That's way off the norm, right? So I think we've got a younger population right now, right? So
They all had it at Michigan.
okay, they all had it. It
was not in the States.
was not in the States. Okay, that's actually important, right? So out of US, but we did see a few hands, right? And so this is kind of our story as it relates to opioids. And one of our papers got a lot of attention a few years ago, and they did a segment on CBS Morning News, and they interviewed me about the paper. But when I went to watch the spot, I was actually kind of caught off guard, because what I didn't know is the story that would come with it. And it's a woman named Sage, and her mom's telling the story of Sage being this bright, energetic young woman who at the age of 20 had her wisdom teeth extracted. And that was her first exposure to oxycodone. And after she got that first oxycodone and started using oxycodone more, eventually started using heroin and has passed from a heroin overdose. And now the story went on to have grandma talk about raising her granddaughter because mom was gone. And that's a powerful story. And her mom and her Sage's mom and I have spoken a couple of times. She's agreed to let me tell that story, use pictures, do whatever we can, because she's so passionate about it. And the thing is, we can start with sort of the doom and gloom of it, because that's where everybody goes for the opioid crisis. But the reality is that in dentistry and in oral surgery, you're way ahead. I do most of my work in surgery, anesthesiology, and now some in emergency medicine. But dentistry is way ahead. You have level 1 data, randomized control trials showing that nonsteroidals and acetaminophen are as good or maybe better for managing pain post-operatively for extraction, right? And yet, because of concerns about convenience, Yelp, all the different ways that patients will go and complain about you, people give opioids as a convenience. And I have people in the opioid space who say, well, you know, Chad, is 10 or 20 pills really going to change things? And the answer is yes, right? But not just as we think about dependence or misuse, right? When we look at surgical patients, 80% of people given opioids for surgery get analgesia. That might be less or more than you would expect. But 80% of patients also have a moderate to severe side effect. And by that, I mean constipation, nausea, vomiting, dizziness, sedation, right? So you're giving something where the chances of having a side effect are as good as getting analgesia. And yet you have data to show that acetaminophen and ibuprofen are superior. Not only that, your dental association, your biggest American Dental Association, has said, hey, you know, keep it less than 7 days. Now they started to modify that language. You can give opioids for less than 7 days. I wish they had said nothing, right? Because the reality is that 7 days is a lot of medication. In 7 days, you can become dependent. And I'm not talking about addiction or opioid use disorder. The reality is that prescribing has declined year over year for dentistry, as has with all types of care. But actually, and we haven't published this data yet, Cao Chu is leading this, there's a pretty strong signal using some of the most contemporary data that prescribing has flattened off or maybe even slightly increased during this post-COVID era, that any gains we were making. And you say, well, I've had many dentists and neurosurgeons come to me and say, what about this? And they'll grab the most painful case you could ever imagine that you might do once a year. Sure, not asking you to stop being a doctor. Be a doctor, make a decision. When it's appropriate, use it. But 66% of the opioids written in the United States right now are written for tooth extraction. And there's about 10 or 11 million prescriptions per year in the United States, right? So the idea that this isn't happening is just flawed. Not only that, when you think about kids, vulnerable populations, adolescents, Sage as an individual, as a human being, the most common prescriber beyond pediatricians is dentists and oral surgeons. You often prescribe the first medication. And if you need the narratives, go to the high schools. Kids know when other kids are having dental extractions, and they say, hey, if you've got any extra pills, I'll give you $5 a pill, right? So there is opportunity here well beyond. Now, when we think about policy, and as I sort of like think about where we are, wrap this up and hand off to our next speaker, Kim Gatica is in the back. She was previously with the licensing board. When she started our MAPS, the prescription drug monitoring program, as well as a number of other policies that came through, all well intended. And I think Kostanecki, who's the policy lead for IHPI, she was telling me many years ago, at the height of this crisis, there was more than a bill per day being proposed related to opioids. around the country. All well intended, but actually, unfortunately, as we've looked at these policies now, and again, credit to Kauchua, we're not seeing any effect, and it makes sense. A 7-day limit, state limit, isn't going to change anything because you don't write 7 days very often, right? Some of these other things that we're looking at, the one thing that may be a factor, and we're looking at now, is the PDMP, and I think this really comes down to the inconvenience, where dentists and oral surgeons are saying, that's just too much. I'll just stop. They'll finally comply. But I think if I was to sort of summarize, to wrap it up, you're ahead in the opioid space because you have some of the best data with respect to efficacy or lack of efficacy for opioids. You need to think beyond just the convenience and the satisfaction, and maybe during the Q&A, we can talk about what really drives satisfaction in acute care and how you can have great satisfaction without putting an opioid as dispenser in your lobby, right? That you can have great satisfaction without prescribing opioid, maybe even better satisfaction. But that think about the common side effects, not making people nauseous, vomit, constipated, right? But also thinking about dependence. And I even had to learn which teeth were the wisdom teeth. So, I mean, we've done a lot of work in this space, and I really think that this is a great opportunity. And I'm excited that the School of Dentistry here, it has really differentiated itself from other schools of dentistry in terms of educating about safe and responsible use of opioids. Thanks.
Thanks, Dr. Brummett. I wish we had more time because there's so many amazing things Michigan Open is doing. So, for example, they commissioned a musical to talk about the journey to addiction. They've done a study showing that we prescribe more on Fridays than Mondays. There's so much fascinating work we don't have time for. But thanks, Dr. Brummett. Now, Dr. Adrienne Lapidos, who is also no stranger to the School of Dentistry, used to lecture in one of our hygiene courses, and Dr. Ruley's there at the back. So Dr. Lapidos is a licensed clinical psychologist and clinical assistant professor at the University of Michigan Medical School Department of Psychiatry. Her research focuses on novel interventions led by community health workers that integrate physical, behavioral, and oral health. She's particularly interested in the problem of health disparities among people with severe mental illness. And as a practicing clinical psychologist at Michigan Medicine, she provides psychotherapy and evaluation services for patients with psychosis and depression and PTSD. So thank you, Dr. Lapidos.
Thanks for having me here, Romesh. So I would like to start with what I think of as a classic definition of mental health recovery by the scholar Bill Anthony. So he's referring here to recovery from severe and persistent mental illnesses like schizophrenia spectrum disorder. And he says that mental health recovery is a way of living a satisfying, hopeful, and contributing life, even with the limitations caused by the illness. So Bill Anthony's classic paper in 1993 came at a time when most psychiatric writings were defining recovery as a complete remission from symptoms. So the 90s were a time in history of psychiatry when people were developing an interest in the notion that recovery from severe mental illness was more about living with symptoms as opposed to overcoming them completely. So my project team and I were very influenced by this notion of mental health recovery when we started looking at the problem of oral health among people living with severe and persistent mental illnesses like schizophrenia. I'll refer to that as SMI, serious mental illness, which is a term that we use broadly for schizophrenia spectrum disorder. And what we noticed when we started looking into it was that almost all public-facing materials that discussed oral health were focused on children and were focused on prevention. Now, I love prevention. I've got nothing against prevention. Prevention is wonderful, but for a lot of the people that I serve, people with really severe mental illnesses, the prevention ship has pretty much sailed. People have decayed teeth, missing teeth, poorly fitted dentures. People with SMI have triple the likelihood of being edentulous than the general population. For example, so in this context, an exclusive focus on prevention seemed like it would potentially increase the level of fatalism that people felt about their oral health. So we started asking ourselves, what would oral health recovery look like for the people that we serve? Steve Kisley's excellent paper, which is called No Mental Health Without Oral Health, talks a lot about the many oral health challenges facing people living with severe and persistent mental illnesses, likely due to a confluence of a lot of different factors. So the first among them is medication side effects and xerostomia. But also there's elevated rates of smoking, elevated rates of poverty, which of course impacts nutrition and diet, psychiatric symptoms themselves, like avolition, making it more difficult to maintain oral hygiene, and low access to care because this community is typically insured by Medicaid. His paper also points out that there's a bidirectional relationship between oral health and mental health. So, for example, sleep is disrupted by tooth pain, and social functioning is disrupted by the stigma of having visibly decayed teeth. Recently, the Lancet Psychiatry Commission came together and brought together a group of researchers and stakeholders to think through how to protect the health of people living with mental illness. And their main finding was that integrated care, so like decreasing the fragmentation of the healthcare system, was one way to protect the health of this community. But how do we navigate within our existing fragmented healthcare system, the healthcare system that we have, as opposed to the one that we want, which may actually never come about in our lifetimes? So I'm going to tell you about 3 projects that our team has put together in response to these problems and in the context of this healthcare fragmentation. I've had the very good fortune to be able to work with faculty here at the School of Dentistry on these projects over the years, especially Danny Rulli, who's here with us today, but also with great support from Jennifer Cullen and Gwozdek when she was here before, and the dental hygiene student, Allison Bittner. The 3 projects I'm going to talk about relate to very particular workforces here in the state of Michigan, and I want to tell you a little bit about who they are before I tell you what the projects are. They are community health workers and peer support specialists. So community health workers are trained frontline health workers who are trusted members of the community being served. So they tend to work in safety net health centers like F3HCs. And an ideal community health worker actually lives in the same neighborhood as the people who are being served. They can serve as a bridge to the medical team and provide lots of ancillary support in that way in the community. Peer support specialists are a specific type of community health worker. Unlike CHWs, peers are typically employed in the behavioral health safety net, like so community mental health, but also VA and forensic settings. And they are people who are in recovery from a mental health problem, who are trained and certified to help others, provide peer support to others sharing similar experiences. Many peer specialists have a history of really severe mental illnesses, have been in the hospital, many of them have been homeless and really kind of lived and walked that journey before attaining full or partial recovery, and obtained training from the Michigan Department of Health and Human Services to provide this peer support in these safety net settings. In project 1, Danny Rulli and I received a grant from the Michigan Health Endowment Fund to develop a series of e-learning modules to teach the basics of oral health to CHWs, community health workers, and peer support specialists. We worked with a community advisory board in the community. We decided on the content of these e-learning modules. We worked to develop them in terms of graphical design, instructional design. We hired a voiceover actress to narrate, and we provided these modules to the Michigan Department of Health and Human Services and also the Michigan Community Health Worker Alliance, or MISHWA, which is the main body that trains and certifies community health workers here in Michigan. And so now these oral health modules are now just a standard part of their training. So they're just fully integrated into their original certifications and also available as continuing education for these workforces. In project 2, again with Danny Rulli, we received a grant from the Delta Dental Foundation to develop an intervention that is delivered by community health workers and peers, designed to fit the needs of people with severe and persistent mental illnesses. And we worked with a nonprofit company called Macmillan Health to design durable materials that the peers and CHWs could use to guide a discussion about oral health and to help link those people to care. And in project 3, which just started last month, we're developing a group-based intervention where a peer or a CHW can teach a class in a community mental health setting and then follow up with people individually to try to link them to a dental home and also provide support for oral health related behavior change. So, you know, I consider myself basically an intervention researcher, but the approach does have significant policy implications because of the fact that peer specialists are sustainably financed by Medicaid, like direct Medicaid billing in safety net settings. They have their own billing codes, sustainably financed workforce. Just as of fall 2022, community health workers are starting to receive the same treatment by the state. So there's some policy changes that are working toward the financial sustainability of CHWs. So what I hope to be illustrating to all of you is, like, first of all, the special vulnerability of people living with these severe psychiatric disorders, but also that due to these recent policy changes, we have at our fingertips these great workforces that really understand the community, who can be excellent partners to us in developing a public health approach to improving oral health in underserved communities.
Thank you. Thanks, Dr. Lapidos. And I was thinking it's probably about 10 years since you first partnered with our school, you know, because I think the first thing was a paper that you did on failed appointments, trends in failed appointments with Ann Grosdick. So that's a long relationship with our school. So, you know, all of our 3 speakers and many others are doing this amazing work in oral health, but none of them are dentists, you know, but the connecting factor is they're all IHPI members. And through that work, they see the need. Right? They see the need that we have in oral health across our communities. So now it's my pleasure to introduce Dr. Ola Rostant, who is an assistant research scientist with the Health and Retirement Study at the Institute for Social Research. She has a Ph.D. in quantitative psychology from Michigan State University. Dr. Rostant's substantive research includes cognitive aging, oral health, multi-morbidities, and mental health among African Americans. Her methodological work focuses on longitudinal modeling, survey and instrument development, and measurement and variance of health outcomes, of oral health, of health outcomes. Dr. Rostant.
Thank you, Romesh. Really happy to be here. I'm kind of a newbie to the whole oral health space relative to my colleagues, but currently, my work around oral health focuses on the intersection of oral health and multi-morbidities in older adults and looking at that across time. So I'm looking at the intersection of dementia risk and oral health, hypertension and diabetes, as well as depression, and developing an intervention program in which I'm sort of thinking about oral health as a non-traditional modifiable risk factor, that it's co-occurring with other physical illnesses, but there's not the integration that there should be in order to be treating them at the same time, in order to, I feel like they're reinforcing one another in many ways in terms of the inflammatory mechanism that they both sort of follow. In terms of the data that I use, I leverage large epidemiological studies like the Health and Retirement Study, the Handle study at NIH, M.H.C.M, and the National Survey of Social Life. And I basically, because I'm like a lab rat in that way, I scour these large data sets for any information on oral health, and then I start basically, you know, developing ideas and then testing models. And that's sort of where I am currently, and looking for collaborators and things like that. So I'm really excited about the opportunities that can come from this meeting today. Thank you.
Terrific. So folks, we have a few pre-submitted questions. And you know, after that, I also welcome the audience. And then if you're watching online, please submit your questions, and Eric, I'll lean on you to let me know of that. So first question is actually for Dr. Brummett. Are there examples of ways in which your research has led to change in state officials' programming and policy, or even change in mindset, like in the delivery of care and policy?
Yeah, I mean, on the policy side, I think we're still growing. I mean, before I was exposed to IHPI, I didn't really think about policy a lot. I thought a lot about the dependent variable in my model, or, tried to think about what covariates would go in, or what I wanted to study, but I didn't really think about policy. And I still remember my first time in Lansing, and a very powerful policymaker said, help me make my bill better. And I wasn't ready. And I left that meeting and I said, I can't ever do that again, because that was an opportunity and I missed that opportunity. I think we've been welcome in Lansing, and I think the entirety of Open is related to policy in a way, because we are a Medicaid match program. So we leverage dollars from Blue Cross Blue Shield as well as institutional dollars to draw down federal dollars, and that's in direct partnership with our Michigan Department of Health and Human Services Medicaid office, as well as directly with Blue Cross Blue Shield of Michigan. And so in many ways, it's very interesting that we sort of sit as the, public institution working with the largest public payer and the largest private payer in our state to influence care. And in doing so, are able to leverage networks around the state, less so in dentistry, but more in surgery and emergency medicine and other aspects of acute care, to bring physicians together multiple times a year to have them be part of change. And what I mean by that is that what I've learned in practice, because I agree with what you said, you publish the paper and things have just started, right? Disseminating that information became important, but not surprisingly, early on in our dissemination efforts, everybody said, well, that couldn't work here, or my patients are so much different. And I think where it's been helpful is actually using their data to make our recommendations and then disseminating that back to them. And so engaging with people, and one of our early medical students, now a senior resident, Ryan Howard, took it a step further and basically published a toolkit. Like, you don't believe our prescribing recommendations. This is how we came up with our first one. Here it is. You can do this in your own office. You can do your own quality improvement studies. We still do work on brain imaging and genetics and all these other, more traditional science approaches. But I think the quality improvement space is really satisfying when you compare it with practice change. And so, I'm sure there's many more ways in which we've looked at policy, and we're going to continue, I think, to push on the policy button as we go forward, because we're starting to get a better sense of what matters. But I think that that just being present, being knowledgeable, because it turns out most of our policymakers want that information, and also being ready to tell stories that go with the data. I think those are the things that I've learned through this process.
Yeah. And one thing relevant, Chad, of your work to this audience is that Michigan Open co-authored the dental opioid prescribing guidelines for this state. So when you go to the MDHHS website and download it, you'll see at the bottom acknowledgement of Michigan Open.
Hopefully it doesn't make you angry. If it does, Romesh also helps.
But one thing that I really like about it is it starts to talk about non-medication approaches to manage pain, which is common in many countries. And then it goes to, well, when you need a medication, here are the options. So I thought it was very nicely done. So Dr. Rostant, a question for you. Okay, you're studying aging, and aging, as we know, affects oral health too. So what are the opportunities that you see for deeper study of the connection between oral and overall health?
Well, if I just think about the relationship between Alzheimer's and dementia and tooth loss or oral health. Currently, there's sort of 3 avenues in the research space that people are trying to explore, where you look at the relationship between the blood-brain barrier, so having infection in the mouth and what that might be doing to the brain itself. And then more of an upstream approach, which is if someone has missing teeth or no teeth or dental pain, the quality of their diet is not that great. So you can't really have a nutritionally dense diet, which then exposes you to increase your risk for things like vascular disease, which then increases your risk for dementia. So there are a couple of steps in terms of the relationship. And then lastly, before coming to Michigan, I was at the National Institutes for Health on the intramural research side. And they're not many social scientists, mostly bench scientists. They talk about rat models, things I know nothing about. And one of said bench scientists knocked on my door one day and said, hey, we just had a guy come and speak about, rats with no teeth and impaired executive functioning. You need to look at that in humans. And I was like, that's insane. But I wrote it down in my lab book. A couple months pass and I fall down this rabbit hole. And I'm like, oh, I would have never thought of such a thing. And there actually isn't quite a lot of work in humans, but also thinking about the idea that, and correct me if I say it incorrectly, but mastication, being able to chew, is connected to blood flow in the frontal lobe and executive function. So if you're not chewing, there may be atrophy, and that may be what we're seeing and not necessarily cognitive decline. So those are sort of the things that are floating out there and where my passion is at the moment.
Very, very interesting. So you segued nicely to mental health. My next question is for Dr. Lapidos. So Dr. Lapidos, your focus in care delivery is mental health. You're a clinical, you still practice, you still take care of patients. But what do you see in terms of the opportunity to integrate oral health education into primary care? And then of course, behavioral health as well.
I think what's great about this space is that there's a lot of low-hanging fruit. There's actually a lot that we can do, which is kind of encouraging sometimes when you see all the world's problems that are so intractable. And so simply learning more, and increasing the salience of oral health to overall health, mental health, and well-being can do a lot, because the conversations then shift between the provider and the patient. And I think that's especially the case in mental health care. I think there's been a lot of dental primary care integration efforts that I'm aware of that are really effective and that improve the understanding of primary care physicians and allied health professionals that better understand oral health, but that hasn't really permeated the mental health world as much. And I think simply improving the level of awareness and education among providers is a really big step. I also think that these ancillary providers that are community-based, whether they're peers, CHWs, peer recovery coaches, lots of different workers can raise awareness about the importance of oral health. And, I have been in the space for a while, but I can clearly remember before I was, and having only the dimmest understanding of why oral health was important. It was really just not something I had given any thought to. And I think most people are actually like that. You kind of forget that that's the case when you're in the space. And then you realize like, oh yeah, people just don't think of it that much. So simply educating people and then leveraging members of the workforce that don't already have their days completely booked up with duties. And that's, to me, peers and CHWs are kind of ideal candidates to have these tough, potentially stigmatizing conversations with people about oral health.
Terrific. I'm going to ask a cheeky little question, and then we'll go to the audience. So my question is, you've all worked in oral health a lot, but you're not dentists. So what has been the most surprising thing that you learned about our profession?
I have an answer to that, which is like, when I've conceived of dentistry, like before I was kind of more immersed in the world, I thought of it as extremely straightforward relative to mental health. I was like, wow, it must be so satisfying to just see a hole in someone's tooth and just fill it and the problem is solved. Like that must be really great. And then once I got in the weeds, I was like, well, it's actually not that different from mental health, because then they come back 6 months later and maybe like the filling is ruined for some reason, or whatever might be going on in between the visits might actually be what's driving the problem. So it makes it not actually that different from psychiatric management, not as different as I imagined originally. So I think that to me was the surprise, like the lack of straightforwardness of the process of healing somebody in dentistry.
Right.
I think the biggest surprise for me, because I work in a world where it's constant data, was that I couldn't get my hands on any data. As I met with Romesh and several other people in the School of Dentistry, and they're like, no, not that. So that continues to perplex me as to why there's not more oral public health data.
Yeah, I mean, that's interesting. It's not what I was gonna say, but that is a barrier to some of what we do, and the medical insurance pays for the opioid and the dental care is paid for either out of pocket or through another provider. And so large data sets of good opioid and or pain and or together with dentistry data are lacking. But that's what I was actually going to say is, you know, when we started working in the space, we were largely working with surgeons, you know, general surgery, gynecologic surgery, vascular surgery. They're pretty welcoming, pretty happy to have us, tell us what to do. And I have found, I'll be direct, that it is more mixed in the dentistry space, much more mixed, with some people very much interested, get it right away, and or are just curious and want to learn more. And then I found the opposite, which is dentists aren't the problem. You're looking in the wrong place, and me giving some opioids not going to hurt anybody. And so I think the solution to that we found, though, is having this handsome, articulate guy with us whenever we go anywhere. And I think
So that I can get yelled at instead of.
that's true, though, of everything we do. So having a provider, in especially if you're going to do practice change, and this is probably even true if you're a general dentist and you're doing work in a different domain, you need to take somebody who does that because they need to hear from their own. And so I think that having dentists introduced, because the most powerful thing that happens, we did a panel for 400 people in Flint, dentists, and I get done, and one guy raised his hand and says, I haven't prescribed an opioid in a year and a half, and I do 700 third molars a year. And all of a sudden, everyone at the table stopped listening to me and went straight into him, and they're talking. And I can tell you, there were probably like 8 more people that left not prescribing after that. It had nothing to do with what I said. It was just giving him a forum to raise his hand and say, I don't do this anymore.
So, audience members, what questions do you have?
Hi, my name is Emily Holder-Thompson. I used to work in Oregon Medicaid, and in Oregon, water fluoridation is a big issue, and children's oral health is a huge issue. And what has surprised me about dentistry, not knowing a lot about it, was the raising school absenteeism related to or oral health. And I wondered what that's like in Michigan. Spoke a little bit about children and youth, but what kind of concerns do we have around children and oral health and just connections with public health here?
Okay, I'll just repeat the question to make sure folks on Zoom heard it. So the question is really, what about children in Michigan and their oral health? And, you know, we talked about there's a significant amount of absenteeism that's related to oral health problems. So I'm not sure if anyone has a response to that question.
I'm at the opposite end of the development.
Yeah. So you know, one of the things is, you know, it's a federal mandate that protects the Medicaid rate for children across this country, and so reimbursement is pretty good. And so there's a lot of players in terms of access to care. Where I think it would get difficult is up north, where there's fewer providers. But I think generally, and that's why I think a lot of us have turned our attention to adults, because vulnerable adults don't have that kind of support. But children, it's really, I think the big barrier is geographical access, because the Medicaid insurance is reasonably good for them. And that has not been the case historically for adults, but many of you know that there's significant changes happening with Medicaid on the adult side in this state as well, but it remains a challenge nationally. You know, one of the things, I'll try and tell this real quickly, but when I came here, we did a lot of advocacy in Lansing, because we had done a lot of research on emergency room visits for dental problems. And we had done it on a national level, and they kept saying, you know, you've got to get Michigan data. And so, you know, we did a lot of complex calculations to get estimates for Michigan. But, you know, now we're working with the real Michigan data. It's much worse. It's much worse than our estimation. So emergency room visits for dental problems in this state is much worse than I would have estimated looking at national figures. Yeah. Terrific question. Other questions? John?
Adrienne, you talked about the role of community health workers connecting people with dental services. Can you speak to sort of lessons learned if the community health workers are well trained are the dental providers ready to step forward and take the referrals and provide the care? And how does that vary across the state, and the role of community health centers providing dental care, private practices, hospital-based clinics? Just would be interested, and maybe as a corollary to that, you co-led a study that IHPI helped to organize with community health workers in Detroit, actually a randomized trial having community health workers work with Medicaid health plans. And were there any lessons learned there about helping through the community health workers, helping people connect to the dental services they need?
Absolutely. So I think, well, first of all, health centers, FQHCs are the best referral source for us. I think as we designed these interventions, one of our concerns or anxieties was that we would get people excited about getting access to oral health services, and then they would encounter insurmountable barriers to accessing care. And to some extent, that is what happened. You know, people would say, okay, I'm ready to make my appointment, and there's nobody in their catchment area. They had transportation barriers. So, you know, we were looking at, you know, what is modifiable in this scenario and what isn't. Our approach doesn't really touch upon the access issues when it comes to location or cost or things like that. What we were hoping to shift within people was things like motivation, anxiety, so just fear, so that those of them that actually did have access to these wonderful health centers would actually utilize the benefit that they actually have and have access to. So it kind of comes with this sense of, you know, we're doing what we can to improve access when it comes to access as a state of mind, as opposed to access as like a literal truth in people's lives. And there were some people we worked with that we really wanted to refer to dental care that we were unsuccessful in doing so. And I do think that speaks to that policy angle. You know, how do we improve the access from a geographical point of view, from a cost point of view, even while looking at what's modifiable from a psychological point of view in terms of fear, in terms of fatalism, and in terms of people knowing their own benefits is another thing. I think Edie Keeper is here, and some of her work indicated that people are not even aware of the benefits that they actually have. So even providing some education around the, you know, you're actually entitled to this and you can use it, might actually shift things for a subset of the population.
Hi, sort of a related question. I'm a Tony Spinkus, I'm an economist, so I'll bring some non-dentist question perspective. I would be interested to know what extent behavioral interventions, trying to perhaps alleviate cognitive limitations, reminders, patients are valued, and to what extent there's interest in moving a step forward from just an assessment of evaluation, a neutral nudge, to a nudge that could shift care from standardized deep cleaning to something that would have also preventive care benefits like periodontal evaluation, disease evaluation. So I don't know if nudging patients is something of interest from an evaluation standpoint, and to what extent expanding the types of treatments would be effective.
Okay. So your first question was about triggers and reminders that may accompany improvement of health, right?
There's evidence of that, and I wonder if perhaps there's an interest in more.
Yeah, I'm not sure if anyone has an answer to that. So, you know, I wish Laurie Lewis was here, because she does this work in high blood pressure, sending reminders and texts to patients to manage their blood pressure. So, you know, at the moment, and this sort of comes back to how limited our data is in dentistry, and it's to do with how limited, honestly, our health record is. And so one of the things at this school is there's been a commitment to go to EPIC. So in EPIC, there'll be more opportunity for some of these interventions and partnering with primary care and you know, different things like that going forward. But there are studies, to be honest, I'm not exactly familiar with the literature of how beneficial it's been, but there are some studies with like text reminders and things of that nature. We are also capable of doing that, but this is an interesting challenge. We have a bunch of phone numbers for our patients, but it's not clear whether they are cell numbers or not. So in our reminder mechanism that we have, we could send texts and have preventive information and things of that nature. So all of this I hope will be refined as we move to EPIC. So-
We do a little bit of behavioral economics in our group, so like but more on the provider side, best practice alerts, which aren't, I generally roll them, but actually had a pretty great effect in hysterectomy prescribing and actually really reduced the number of patients going home with too much opioid. We've done some default limits, which aren't really a nudge, and then working with a group at RAND, just finished a trial there, Sutter Health System, with email and a randomized email intervention to providers with both a guideline nudge and then a peer comparison nudge. And it appears to have had effect. I mean, I think they're still working through the data. But I think the behavioral economic space is really interesting space. We haven't really thought about it as much as it relates to patients. But certainly, I think there's a lot of opportunities. You said in an electronic world where I think the three of us, congratulations to you, three of us have our phone up here, right? So like, it really could be very effective. It's something we're probably not utilizing well.
And then not exactly behavioral economics, but one of the things we've thought about, as we go into EPIC is reminders to clinicians. And of course, I think dentists could serve overall health better as well, but because we're dentists, we focus on the oral health. And some of the things I think about is when a patient is first diagnosed with diabetes, they should immediately be referred to the dentist because there's evidence of bidirectional relationship, and a failure to treat dental for a diabetic patient is failure to treat diabetes. And then there's 15 years of evidence that periodontal disease is associated with low birth weight and preterm birth. And so if someone is planning a family, one of the first things is to get a dental. So there's a lot of these reminders that I think could happen within the microcosm of EPIC. Question?
Yes, I have a couple questions from the live stream.
Terrific.
So the first one is for Dr. Lapidos, and it's about whether you can talk more about working with a community advisory board.
Oh, sure. So, I mean, working with a community advisory board is completely central to all of these projects. We honestly would not know what to do if the community advisory board was not telling us what is important to them and their community. And so typically it's actually pretty simple. We have meetings either every other month or quarterly, and we meet with representatives from the community that we're trying to design this intervention for. We basically ask them, hey, how's this going to look to people? And what do you think is, how's this going to fly? And we've gotten some super interesting feedback, like sometimes kind of counterintuitive feedback from people. Like, for example, in the materials we were developing, we wanted to have a smoking cessation page where we talk about how bad smoking is and all. And they were kind of like, don't do that. They said, you can have a small section on smoking, but we're smoking for a lot of reasons, and it's going to turn people off from what you're doing if you're focusing too much on smoking. So we ended up having a page just with like various habits. Among them was smoking, but we sugar intake there as well, just to kind of destigmatize smoking. It's just a small example. And again, I feel like I'm a broken record with CHWs and peers, but they're like ideal community advisory board members because they're kind of like in this in-between space. They're consumers and providers. They're experts, and they're also from the community, and they're able to kind of translate ideas back and forth between the researcher and the community.
I have people tell them things that they wouldn't tell a physician or a nurse.
Yeah.
They'll say something to them that they feel more accessible to.
Yeah, and in fact, smoking is one of the things that happens there. Well, they'll tell their nurse, I plan to quit smoking, and then they'll tell their peer, like, it's not going to happen. Let's work on something else.
Wow. Erica, there's another question, was there?
Yes, we've also gotten a few questions from I think students, trainees, researchers who are interested in getting involved in that space. Either they have a background in dentistry, but also in another discipline, or they're coming just like our presenters here from other fields and are wondering where there are opportunities in this space to working and advancing these priorities and also their as well.
Terrific. So we actually have a lot of trainees in our room as well. So I guess if you could speak to how a new researcher would get into the oral health space.
Yeah, I mean, we've supported a lot of people throughout varied levels of trainings, undergrads, medical students, dental students, nursing students, residents, junior faculty, fellows, so across the space. we have access to a lot of data in part through the IHPI data core, and then some data that we maintain independently. We have analysts. I will say that we probably suffer from the problem of, well, a lot of gold and not enough gold miners. The challenge, I think, becomes getting good mentorship. So I think coming in from a dentistry space, having somebody else, maybe a faculty, or whether it be Romesh or someone else who has interest if you're a student, that's very helpful. I will say all the principal investigators within Open have plenty of papers. That's not a limit for us, so we don't really sit around and fret about who's going to be where on a paper. It's more about how do we advance understanding, how do we advance people in their careers. And so we've been very successful. I will say we've got processes. We have analytic memos. You have to write an analytic memo. You have to show you have to write an introduction into methods, and we have to think about what's there. But if you show those signs, then we have a lot of data. I mean, and a shocking amount of data.
I work with students all the time, publish with students all the time. Pretty sure you'll find my email at the end of the presentation, so feel free to reach out and we can brainstorm an idea. I'm always.
Thank you, sir. Yes, you have a question?
What are your thoughts on
Integrating, so the question is, what are the thoughts on integrating medical and dental care?
Yes.
I think it's probably a firm yes from all of us, but as you can imagine, there's a lot of challenges, right? So one of the first challenges is dental is not always part of insurance. So a patient may have medical insurance and then not dental insurance. Next challenge is we're not co-located, right? So the dental profession grew up in a very different way to the medical profession. And so we are largely small practices around the community and not hospital-based. I think it's 1% or less than 1% of dentists are based in a hospital. We're mostly in our practices. So there are some logistical challenges, but I think, there needs to be movement towards this, of course. So it's necessary, but challenging. So let's take your question, and then I think we've got to finish up.
It's not a question. One of the places happen is in federally qualified health centers, because they're all in one location. They don't all have dental practices.
Question?
I just wanted to add on that. I'm a dental hygiene student, and I think that my group had done research based off of nurse practitioners and including their curriculum. And we found that within their curriculum, there's not much about oral health, which is the basics of like oral cancer screenings and stuff like that. But there wasn't much in depth like systemic links, how they correlate, and more about that, so that way they can know where to refer. Like most of the patients that start seeing physicians before actual dental providers or dental hygiene providers, and then they come in at the age of when they first had their first caries, and then they go, oh, I wish it came earlier, but that should have been something addressed earlier. And I feel like it's a lot of research you can find out there, but it's nothing that's been done. So I mean, if they're trying, but I feel like there should be more research about like why is it not integrated into nurse practitioner curriculum? What's missing?
Yeah. Okay, thank you everyone for your comments and participation. We've got to sort of wrap up, but I think the closing thing for IHPI members and dental community folk is that we're sort of at an inflection point in dentistry, right? We have not had good data, but my colleagues here have managed to still do some excellent papers that guide research and practice, but there is an acknowledgement of this problem in dentistry, and there are movements at the ADA level and various levels to improve data collection. ADA has a project actually to centralize data of many practices. And so, like I said, we are moving to EPIC, and many dental schools have already moved to EPIC. So there's an understanding of this problem and efforts to address this. So it's a great opportunity. It's a great moment for young learners, junior faculty to come into the data analytics space and in population health policy research and things of that nature. So before we close, I must thank Erica Solway. Erica, wave your hand. Stacy Trussell, Stacy, Also, Eileen Kostanecki, who helped conceive this idea. John and Trish, always thank you for your leadership of IHPI. As I've said, I really appreciated it and benefited from IHPI. And also Chris Mung, if he's here, I'm not sure, but from our dental community, helped with the IT. So thank you very much for making this happen and welcome again to the School of Dentistry.